stuff that want to like add anything to your exam scores. So I want something that you guys will just be able to relate with for the exam, right? So I've gone through all this. I've taught this with you guys, explained all of this. I've also said this, right? I didn't talk about the abnormal uterine bleed. I'm going to talk about that, but let me just finish with the placenta first. Okay, so yeah, so this is what I wanted to talk about basically, but I don't know whether I spoke about the physiology before I go to the pathology. Did I talk about the physiology in the last class? About how it's formed, the two cells that are responsible, the fetal component and the maternal component. Did I talk about those things? Because I want to know. If I didn't, I want to talk about it because I was going through a U-World question yesterday and I saw a lot of high yield stuff. So I wanted to be sure that I actually talked about it and I'm not skipping some things. Can anybody respond so that I can know where I am? Did I talk about it? Okay, so I guess I did. Okay, so let me just talk about the genetic aspect then. I want to talk about this because it's high yield. So I've spoken about the placenta. So let me just talk about the genetic aspect. So there are like 4 genes that are responsible for the genetic makeup of the fetus. These 4 genes are very high yield. Some of them can come out in your exam. So I want you guys to know about them basically. And so the 4 genes I'm going to talk about, the first one is the Hox gene. Hox gene, right? Second one I'm going to talk about is the sonic hedgehog gene. And I'm sure by now we're used to the sonic hedgehog gene. The next one I'm going to talk about is the WNT7A gene. And then the last one I'm going to talk about basically is the fibroblast growth factor, right? So what do you need to know about the Hox gene? So basically the Hox gene helps with what we call segmental organization. So segmental organization of the fetus. Segmental organization of the fetus. What do I mean by segmental organization of the fetus, right? So basically what happens here is that you have segments. So we have fractions, we have parts. So the fetus has the head, right? So when I mean segmental, we have it kind of like helps to kind of like differentiate the cranium from the caudal aspect. So it helps to kind of delineate the fetus into a cranial caudal kind of like alignment in the womb, right? So it's responsible, the Hox gene is responsible for this segmental organization. So the head develops into the brain, the cranium is the anterior aspect of the head, and then the caudal aspect, the legs and the the genitals are located in that region. So the Hox gene is responsible for the cranial caudal orientation of the fetus. This is very, very important. I'm saying this because it's very, very important for you guys to know. And it's a high yield thing. That's why I'm talking so much about it, right? Now, the other thing I want you guys to understand basically is that the Hox gene is very, very important in this aspect, right? It helps with the expression of genes that are responsible for this segmental organization, meaning it helps to kind of like regulate proteins or help with genes, transcription factors that will help to align the fetus in a cranial caudal orientation. That's what this guy does basically. So they can put it in a question for you guys. I've seen it in a U-World question. That's why I'm actually talking about it so that you guys will help, right? And so you can have a situation where the patient can also have, so a mutation in this situation basically, cranial caudal helps with the extremities as well. So it helps to kind of alienate the left extremity, the right extremity, the right lower extremity, the right lower extremity. So this Hox gene is responsible, apart from the cranial caudal orientation of the fetus, it helps with limb differentiation. So limb differentiation, limb. So it helps with the number of digits that are produced. So the number of digits, let me go down. So the Hox gene helps with two things. So the first one is that it helps with the cranial caudal orientation, right? The second one is that it helps with um, limb orientation. Helps with limb orientation. So if there's a mutation on this gene, what you have basically is that the patient will have a symptom known as polydactyly and syndactyly. So basically, the Hox gene is majorly involved in these two parts. Helps with the cranial caudal orientation of the fetus, and then it also helps with the limbs development. And so the patient can have syndactyly and polydactyly. Very important for you guys to know this for the exam. They can put it in a question, patient has syndactyly, what gene is majorly implicated in that? So you need to know that it's the Hox gene that's implicated in this, right? For the sonic hedgehog gene, the sonic hedgehog gene helps with three things basically. So it helps with the limbs, also it helps with the eyes, and it helps with the brain. It's majorly implicated in these regions. And so a mutation in the sonic hedgehog gene will lead to what we call holoprosencephaly. Sonic hedgehog gene helps with the development of the limb, the eyes, and the brain. And so if there's a mutation in this gene, the patient will have holoprosencephaly. So think about it. In a patient with holoprosencephaly has a cyclopia eyes, he has a monoventricle and a fused brain, he has limb abnormalities. So you can just kind of think it out basically. You can just reason it out basically, right? In what happens. Now, another thing I just want to mention, the two last genes are important. So I'm going to draw something to help you guys remember the two last genes, just for the exam purposes, right? And so we have this region here. It's very worthy to note. So this is the mesoderm. And then you have a region here, right? This is known as the AER. And this is known as the apical ectodermal ridge. So the mesoderm is the part of this diagram that rapidly divides, right? And so what basically happens is that the fibroblast growth factor FGF helps with the growth. It's secreted by this mesoderm here on this apical ridge. So the mesoderm secretes FGF because, of course, the mesoderm is the part of the body that has connective tissues, and the fibroblasts are the ones that kind of secretes the fibroblast growth factor, which is FGF. And so it helps with the what do you call it now? Helps with the growth of this region, the apical epidermal ridge. Not only that, what it also does basically is to try to give the limbs a proximal to distal orientation. So the fibroblast growth factor gives the limb a proximal to distal orientation. And then not only that, the mesoderm also secretes what we call WNT7A. And what this gene does is that it gives the limb what we call a flexor and extensor orientation. So basically, let me explain this to make sense to you guys. So what happens here is that if you have an adult limb, so this is like the proximal and this is the distal. The fibroblast growth factor helps with the orientation of these two regions. So FGF. And then this is the extensor and this is the flexor. So this is flexor, extensor. The WNT7A gene is responsible for this orientation, while the fibroblast growth factor is responsible for the dorsal, the distal, and the proximal region of the brain. I saw it in a U-World question and I said I should discuss this with you guys because it's very high yield and you guys need to know it for the exams, right? And so I don't know if that makes sense, guys, if that's very clear or it makes sense to you guys at all. Okay, so what I was trying to say basically is that there's a part of reproduction that has to do with genetics. And the genetic aspect involves knowing the genes that are responsible for certain developments in the brain and the body. And I said that there are 4 types of genes that you should know. The first one you need to know is the Hox gene. The second one I said is the Sonic Hedgehog gene. And the other 2 is the fibroblast growth factor and then the WNT7A gene. So this gene is the third one and this is the fourth one. And what I was just trying to say basically is that if you have a mutation in the Hox gene, the patient most likely comes down with syndactyly and polydactyly. That means the patient is having fused digits or more than 5 digits. That's what you have in the Hox gene. In the Sonic Hedgehog gene, it's expressed by certain tissues, the neural tissues, the eye, and the limbs. And so a mutation in Sonic Hedgehog gene is what you have in holoprosencephaly. That's what you have. If this Sonic Hedgehog gene is mutated, you have what we call holoprosencephaly, right? I now drew this diagram showing the mesoderm of the fetus and a region called the apical epidermal ridge, right? Which is just directly on top of the mesoderm. The mesoderm secretes the fibroblast growth factor that causes rapid growth of the mesoderm, not this AER region. The AER region secretes this growth-like factor known as along with the mesoderm, secretes this WNT7A. And what this WNT7A does is that it causes the limbs of the fetus, to be oriented in a way of flexor and extensor. So this flexor and the extensors, you are able to have that orientation in utero because of this gene known as WNT7A gene. And then the proximal to the distal growth that occurs in the fetus in limb development is as a result of the fibroblast growth factor, which is what the mesoderm secretes, basically. That's what I'm just trying to say. So Kingsley, what I'm just trying to say, let me explain it again, right? There are 4 genes that are responsible for in utero development of the fetus. The first one is the Hox gene. The Hox gene is important in developing our limbs, our digits of the limbs. So if there's a mutation in the Hox genes, the patient will come down with syndactyly or polydactyly. That's the HOX gene. A mutation in that will cause syndactyly and polydactyly. But the other gene known as Sonic Hedgehog gene is responsible for both the brain, the eye, and then the limbs development. A mutation in this gene, Sonic Hedgehog gene, will lead to a condition known as holoprosencephaly, which we did in the neurology section. And then the patient will have symptoms such as fused eyes, we have fused brain, and a monoventricle, and then limb abnormalities. The Sonic Hedgehog gene mutation is implicated in that condition that caused all these symptoms that I'm talking about. And that condition is known as holoprosencephaly. And then I now drew a diagram showing the mesoderm and the apical ectodermal ridge. growing side by side. Within the first and second trimester, the apical epidermal ridge secretes growth factors that help with the growth of the mesoderm and orientation of the limb. And so the apical epidermal ridge secretes a chemical or a gene known as the WNT7A gene. And this gene helps to kind of like produce transcription factors that will help to orientate the limb into what we call an extensor and flexor. Extensors and flexors. That's what the WNT gene, NT7A gene does. I'm not saying that the fibroblast growth factor is more produced by the mesoderm. And what it does is that it causes rapid proliferation of the cells in the mesoderm so that the limb grows more outward. So the fibroblast growth factor helps with proximal to distal orientation. I don't know if that is clear. That's what I'm just trying to say with this genetic aspect. Okay.
It's clear. It's clear. Thanks.
Okay. So now the next thing we're going to talk about basically is what I'm just trying to say, right? Which is the sex chromosome disorders. So I'm going to just explain something, right, to make it a lot more easier. So in meiosis is what you find in sex chromosomes, basically. Meiosis is what you find in cells that are non-somatic. Non-somatic cells includes the sex chromosomes. So we have 22 pairs of autosomes. And then we have one pair of sex chromosomes. And so these sex chromosomes are the ones that are located in the sperm and the eggs. So meiotic disorders, meiotic, not mitotic. Meiotic disorders are found in the sex chromosomes mostly, while mitotic disorders are found in these 22 pairs of autosomes. So it means that sex disorders are more of meiotic disorders. Sex disorders are more of meiotic disorders, not mitotic disorders. And so the disease conditions we're going to discuss about today are sex chromosomes disorders. Hence, the pathology is located in meiotic disorder. What does meiosis means? It means that after the divisions of these sex chromosomes, we're supposed to have, what am I trying to say basically? In meiotic disorders or in meiotic conditions, basically, what we're supposed to have is that a sex chromosome or a zygote or whatever, sex chromosome, let's say the sex chromosome that has XX or XY is supposed to synthesize to form XX, and this XX will divide under primary meiosis or the first meiosis. So here, this point here is synthesis of nuclear material. Right? So the nuclear material is synthesized and duplicated. So these chromosomes have more nuclear materials. And so you have this chromosome here. This one goes here, and then this guy goes here. This is primary meiosis. And then secondary meiosis occurs where each cell becomes a haploid. This is known as secondary meiosis. Now, what happens basically in meiosis is that you can see that these two cells separated, right? Ideally, this process here you are seeing basically, what basically happens here is that when there's a separation in meiosis, these two cells, so when two cells come together, when the male and female come together to form a zygote, they are supposed to duplicate and then separate. But basically what happens here in meiosis is that when these cells duplicate, right? When these cells duplicate to form, let's say this is the nuclear materials that are formed, we now have 4x. What now happens here is that in meiosis, right, in the primary meiosis, you would have 3 cells here and then just 1 here in disorders of meiotic so when this happens, where the cells are supposed to separate into two here, so that you can have equal 2 here, what happens in non-disjunction, which is the primary pathophysiology of sex disorders, what happens basically is that you, instead of having that, this is what you have. So there will be a duplication of this chromosome. So let's say we now have 4 here. This is 2 that became 4. So normally, the normal thing you're supposed to have is there's a division here that divides this cell into 2. But in non-disjunction, which is the primary pathophysiology of these sex disorders, the division will occur somewhere here. And so you have 2 cells with one having more chromosome than the other. So this one will be having 3, and this guy will be having 1. And so that's what basically happens in sex chromosome disorders. So there's a meiotic non-disjunction basically of the chromosomes, and it's an aneuploidy. Aneuploidy simply just means an unequal number of chromosomes. So when anytime you have an unequal number of chromosomes, you call that an aneuploidy. So 2 of them together are called an aneuploidy. And so we have 2 types of aneuploidy. We can have a trisomy, which is what you have here, and then we can have a monosomy. Right? We can have a monosomy. And so these sex disorders is what we're going to talk about. So in Klinefelter syndrome, because they test this a lot in the exams, and I want you guys to know this basically, we're going to talk about the difference in both of them. In Klinefelter syndrome, the primary gender that is affected in Klinefelter syndrome is a male, while in Turner syndrome, which is a monosomy, Turner syndrome is a monosomy. So Turner syndrome is a monosomy. So let's just write the differences between both of them. So this is Klinefelter syndrome, and this is Turner syndrome. So this one affects male, and it's as a result of a non-disjunction. So the chromosome is 47XXY. And this one is just a monosomy. So it's just what do you call it? A female with 45XO. So one of the chromosomes is missing, basically. The other thing you need to know about it basically is that 2 of them have a reduced gonad. So in a patient with Klinefelter syndrome, the testicles are very small, but in Turner syndrome, the patient has what we call streak ovaries, or we call it ovarian dysgenesis. And what basically happens here is that in this patient, what we have here is that both testosterone is reduced. Here, estrogen is reduced. Now, this patient here has a bar body. And this one does not have a bar body because of this virtue of this O here, this absent nucleus. And what do we say bar bodies are? So bar bodies is an inactivated X chromosome. So basically, what you have here is that in this patient, basically, this particular patient, one of the chromosomes are inactivated. There's this principle known as principle of lionization, right? Principle of lionization that explains the first and second hit theory. So basically, the principle of lionization is saying that when you have two chromosomes, it's only one that is usually dominant. This is for a female. So what happens in the principle of lionization is that the first injury hits this chromosome, and then the second injury will hit the second chromosome that is active. So for you to have a genetic mutation, two of the chromosomes must be hit. Hitting one alone does not allow the patient to come down with a genetic mutation. The principle of lionization is saying that for a chromosomal abnormality to be affected, for a genetic mutation to occur that will lead to an abnormality, two of the chromosomes need to be hit, not just one. Two must be hit. The first hit will affect the inactivated one. The second hit will affect the activated ones. So both of them will become inactivated. So what I'm trying to say is that a bar body is an inactivated X chromosome. And that's what you have in a trisomy. Trisomy is usually one of the chromosomes are usually inactivated. That is the rule. One must be active, one must be inactivated. But here you have two X chromosomes that are active and one is inactivated. So this patient, these two X chromosomes will make the patient present with more of girl-like features, gynecomastia, tall statures, having this gynecoid habitus, right? Because of these two X chromosomes. And this X one here is inactivated. So an inactivated X chromosome is known as a bar body, and you will have that in Klinefelter, and you will not have that in Turner syndrome. Now, these patients have streak ovaries. I've seen a U-World question where they ask you, a patient has Turner syndrome. Is it possible for this patient to conceive, and how? Yes, they can conceive. One of the ways they can conceive is through IVF. So you must note this. So how do you manage infertility in a patient with Turner syndrome? IVF is the solution. I don't know, is this clear, guys? These patients in Klinefelter are increased risk of, because of testosterone is low, these patients tend to have increased estrogen. And so they tend to have breast tissues, gynecomastia, bilateral gynecomastia. And this is one of the things that is very unique about them, because this gynecomastia increases them puts them at risk of having breast CA. So they can ask you, the patient with Klinefelter syndrome is at risk of having which of the following conditions? Cervical carcinoma. I put PCOS. You can put infertility. They can put some other things. I want you guys to pick breast CA. It's very, very high yield. This is very, very high yield. The same thing with this. Now, the patients with Turner syndrome have other features. They have a widely spaced nipple, a broad chest, a webbed neck, and one of the commonest things that they also have, and it usually asked in the exam, that what investigation would you want to do for a patient with Turner syndrome? Please, you would want to do what we call a renal ultrasound scan. Why do we want to do a renal ultrasound scan? Can anyone tell me why we want to do a renal ultrasound scan for this patient?
It has its association with horseshoe kidney.
Yes, and so these patients are at risk of having an horseshoe-shaped kidney. What artery is usually implicated that does not allow the kidney to rise into the pelvis in patients with Turner syndrome with horseshoe-shaped kidney?
Inferior.
Yes, so inferior mesenteric artery is the artery. Yes, that's correct. Inferior mesenteric artery, right? So now this Klinefelter syndrome that I told you that has a Y, XXY, 47XXY, is different from what we call a double what do you call it now? A double,
Wine.
yes, double Y chromosome, which is what you see here. Double Y chromosome, you can see. So these patients are basically normal. But what gives it away in the exam is this: the patients come down with severe acne. So you see a patient that is perfectly normal, but they tell you in the question that the patient is very tall, has severe acne, very, very severe acne. Please, I want you to think of double Y males. So this is what gives it away in the question. They'll put a normal appearing male, but he's having severe acne. Of course, androgens is meant to cause acne in males, but this one is very, very severe with a normal fertility. This is against a patient with Klinefelter. A patient with Klinefelter, we have reduced fertility. We have reduced fertility. So you can differentiate both of them. When you see a normal patient that's tall but has severe acne with normal fertility, I want you to think of double Y males. When a tall patient has infertility issues, think of Klinefelter syndrome. I don't know if that makes sense, guys. Okay, so now let's go on and talk about the main things, the sex disorders, right? Sex disorders properly. Now, I want you guys to understand something about sex disorders. The first thing I want you guys to do basically is to understand this. This is what I want you guys to understand. When you see in a question, a patient has clitoromegaly, it could mean two things. It could mean two things depending on the gender. If it is a male, it means that the external genitalia is not formed. So it's not properly formed or is deficient. If you see a female, I want you to know that there is increased androgen production. So examples of this is CAH, congenital adrenal hyperplasia. That is one very classical example. And in a male, when you see this, I want you to think more of 5-alpha reductase deficiency. Why am I saying this? When you attempt questions in UWorld, they might want to help you to put clitoromegaly as one of the questions. Another thing I want you to understand is that when they tell you the age of a patient and the gender, they say a 16-year-old male. I always want you to take this information, the age and the gender, especially in the beginning of a sentence. Maybe they tell you question 22. Sorry, my network was really bad. I'm sorry. So, what I wanted to say basically, another thing I forgot to add about this disease condition is that there's a gene that's affected in Turner syndrome. It's called H. So you can be asked this in the exam. This is the gene that's responsible that's majorly affected in Turner syndrome. XHOX gene. Please just know it by the side. They can ask it. You can see it in an MBME question. You can see this is the gene that's implicated in Turner syndrome. Right, Turner syndrome. This is just by the side. The X-HOS gene is implicated in Turner syndrome. So just know that by the side, okay? Okay, sorry. So sorry. Can you see it now? Okay. So the gene I was talking about is this gene. So just know it for the exam. This is the gene that is commonly implicated in Turner syndrome. Sometimes it's asked. I've seen an MBME question on it. MBME 23. MBME 23 has this question where they asked about a girl with widely spaced nipples. What gene is majorly implicated in it? So I've seen a question on this. So you just know this X-HOS gene is commonly implicated in Turner syndrome, right? So now I was saying that when a question is given to you and you are told that the guy is a 16-year-old male or a 16-year-old female, please disregard that information. Why do I mean you should disregard that? Take that information with a little pinch of salt. Do not focus on that information. There are other things in the question that I want you to focus on, but that is not something I want you to focus on. So when you see a question, when they tell you a 16-year-old male, just keep that aside. Keep it in one side of your mind. Don't focus on it too much. I want you to look more at the symptoms and the presentations as against looking at the age. That's the first thing I want you. That's the second thing I want you guys to know. The third thing I want you guys to know is more like a table. I want to explain something to you guys with this table or diagram so that you can understand sex disorders. And when we are talking about it, it makes more sense, right? So when you are giving a question, I want you guys, when you are giving sex disorders, the first thing I want you guys to ask is, does this patient have a uterus? Or the patient does not have a uterus, no uterus. Why am I asking this? Why do you need to ask yourself this question first? A woman, a individual that has a uterus will most likely have an ovary. And what does that mean? It means that the paramesonephric duct was formed. And the only way for the paramesonephric duct to be formed, right, is if this patient is genetically a female. Let me go over it again. When you see a question on sex disorder, the first thing I want you guys to ask yourself, does this patient have a uterus or does this patient not have a uterus? And the reason why you're asking yourself that question is because if the patient has a uterus, it could only implicate one thing, that the internal genitalia organs were formed. Thus, this patient is genetically a female. Does this make sense, guys? This is like the simplest way I can make this thing a lot easier for you guys. So that when you see the questions, you're not bamboozled, you're not taken unaware. That's the first thing you should look for in the question. All that thing about a 16-year-old male, go to the question, look at the question. If the question does not have a uterus, this patient is a male until proven otherwise, genetically. Now, if this patient has a uterus, the next question you want to ask yourself is that, does this patient have a breast? So this no breast, no breast, there's breast. There's uterus, so this is a female. So already this is a female already. This is a female. At this level, we are dealing with a female. But here, this patient does not have a uterus. You go further and ask yourself, yes, the patient is a male. The next question you're going to ask yourself, does he have a breast? Does he not have a breast? So no breast, there's a breast. So at this level, the patient is a male. So we're talking about male. No breast means that this is a normal male, a genetical and anatomical male. Genetical and anatomical male. The next thing we want to ask ourselves here is that this breast that this patient has, what are the causes of this? What do we want to look at next? The next thing we want to look at here is that, does this patient have pubic hair? Or there is no pubic hair? So we want to look, does this patient have a pubic hair or does he not have a pubic hair? If this patient has a pubic hair, this patient most likely has what we call if the patient does not have a pubic hair, the patient does not have a pubic hair, basically, what this patient has is Mullerian agenesis. Is it clear, guys? Is it clear? Don't be confused. Just think about it. The patient has a breast. The patient does not have a uterus. So it could only mean one thing. Genetically, he's a male. The next thing you want to ask yourself, does he have a breast? If the patient has a breast, you want to ask yourself two things. Is there pubic hair? Is there no pubic hair? Breast signifies hormonal production, meaning that there's estrogen in this patient. There's a lot of estrogen in this patient. A lot of estrogen in this patient. That is what it is telling you. That is what that thing is telling you, basically. If the patient does not have pubic hair, it means that testosterone is not even being produced at all. You need testosterone to develop your pubic hair. As males, pubic hair, you need it. Your axillary hair, your pubic hair, you need testosterone. So this patient does not have a breast, but is having breast. Does not have uterus, but is having a breast. And maybe you might see as we go further that this patient might have maybe external genitalias and some things that are kind of like funny, basically. It doesn't have a uterus. They might tell you the question, okay, the uterus ended in a blind-ended pouch, this one and that one, some kind of things like that, basically. They'll put it in the question. And so you have to take note of that. If the patient has pubic hair, it means that testosterone is being produced. And what it just basically means is that testosterone is being produced, but the receptors are not sensitive to it. They are not responding to it. And so estrogen will be produced instead. So the patient will have androgen insensitivity syndrome. But if there's no pubic hair, it means that this patient has Mullerian agenesis. That's how you differentiate it. Okay, let me repeat. Let's go back to this diagram. I said, So this is a male. So it means that genetically there's no uterus. This is a male. So genetically this patient is XY. If the patient does not have any uterus, the next question I want you to ask is that does this patient have a breast or not? If the patient does not have a breast, does not have a uterus, this patient is a male. It's a genetic male and an anatomical male. If this patient has a breast, the next thing you want to ask yourself is that, oh, why is this patient having a breast? Okay, it could only mean two things. It's either androgen is not being produced, which is the most likely cause, or androgen is being produced and this patient is not responding to androgen. So the next thing you want to check is that does this patient have pubic hair? If this patient has pubic hair, it means one thing, that androgens are being produced, though. Androgens are being produced, but the receptors are not, they don't sense it. They don't know that androgens are being produced. And so in that situation, the patient will have androgen insensitivity syndrome. If there is no pubic hair being produced, it means that this patient has Mullerian agenesis. In Mullerian agenesis, the paramesonephric duct is missing. So there's no ovaries, there's no uterus. There's no ovaries, there's no uterus. This patient is a genetical male because the paramesonephric duct is not being produced. And then androgens are being produced basically. And so the androgens go and make this patient look like a male. I don't know if this makes sense, guys.
Yes, it's clear. But in the Mullerian agenesis, there will be presence of ovaries because the paramesonephric ducts makes the fallopian tube, uterus, and the cervix and the upper part of vagina. So we can have ovaries in case of Mullerian agenesis. Am I right, sir?
Yes, in some cases you can have the ovaries. Sometimes they might tell you that, oh, they did an ultrasound scan for the patient. The patient had something that looked like ovaries, but they are not really ovaries. They are non-functional. They are non-functional. Just look at it. The Mullerian duct basically is what forms, what do you call it now? It's what forms the ovaries, the uterus, and then the proximal part of the vagina. So if the Mullerian agenesis means there's no primordial cell there. There's no primordial cell. You know, I use that to explain it to you guys that. But in some cases, in some questions, they might tell you, oh, yes, the patient did an ultrasound scan and then they saw something that looked like ovaries. But this patient genetically is not a female. That's what I'm trying to tell you. Genetically, the patient is not a female. That's why I told you that when you look at the question, I don't want you to look at where they give you a 16-year-old male or female. I don't want you to look at that. That's not what I want you to look at. This algorithm is what I want you to put at the back of your mind. It will help you get most of the questions you're going to answer in the exam. It's going to help you answer a lot of questions. Okay, Azzy, yes, you can answer your question.
Excuse me, but I think that in Mullerian agenesis, the genotype is female, yeah? But you said that it's male and it's
Okay, so I said it was female, right? I said it was male, rather. Oh, okay.
In the diagram, yes, it's a diagram. It's male. So
Okay. So basically, what I want you to do basically is that okay. So basically, what I want you to do basically is that when it comes to the androgen insensitivity, I want you guys to take it as a male. So basically, this is what I want you guys to remember. The male part of it comes here, and then the female part comes here. So just take it like okay. So what I'm trying to do basically is just a way for you guys to remember it, right? So the Mullerian agenesis, basically, the patient is a female genetically, but why I'm putting it on the boy's side is because when you see the patient physically, the patient will have features of a male. So that's why I'm putting it here, basically. It's kind of like for organization purpose. So what I just want you guys to remember from this basically is, so let me just do this so that you can remember it. So genetically, we can put it like this. So let me just label this in Mullerian agenesis. So let me make it easy for you guys. Oh my God. What's happening? Okay, so let me just put it like this. Mullerian agenesis. Mullerian agenesis. So in Mullerian agenesis, basically, let me just put it like this. Patient's a female. So the patient has no uterus, right? Looks like a male. Right? Looks like a male. Looks like a male. External genitalia. External genitalia. Is male-like. Male-like. So let me not say it's a genetic male. I'm sorry for that. It's male-like. So the clitoris look very large. What else again? The patient has features of realization. So what I was just trying to do here is to make you guys the reason why I put it here is my own way of kind of like remembering it. So the XY that when I meant that the patient looks like a male is a way of kind of like remembering it. So I'm sorry if I said it was genetically a male. Sorry about that. So for the Mullerian agenesis, what you need to know is that the patient is genetically a female but looks like a boy. So literally looks like a boy. You have clitoromegaly and all that, and the patient won't have a uterus, right? The patient won't have a uterus. Patient will have features of a breast, basically. So it looks like a guy, right? But in androgen insensitivity syndrome, you have a guy that looks like a girl. So basically, the patient will have pubic hair, will have a breast, but does not have a uterus, right? So the patient doesn't have no external or secondary sexual characteristics. Because the receptors, the testosterone receptors, do not respond to androgens. And so all the androgens will be converted to estrogen. So there'll be a high level of estrogen in this patient. So that's what accounts for the breast and, you know, what you have. In Mullerian agenesis, sometimes you might see the ovaries and sometimes you might not. If you do see the ovaries, the patient genetically is a female, and then sometimes they might have breast and sometimes they might not have breast, depending on what you're seeing. But the patient will appear more like a male, right? So what now happens on the opposite side of the table? The opposite side of the table basically here is that when the patient has the breast and the uterus, the patient is a female, so complete female, right? With the XY, the XX rather. When the patient has a breast and when the patient does not have a breast, you're looking at two things. You're looking at two things. If the patient doesn't have a breast, you look at two things. Okay? So the next thing you want to look at basically is that you want to check the FSH level. So you want to check the FSH level. The FSH, luteinizing hormone and all that, right? So you want to check the FSH level. So for a patient that has reduced FSH level, it means that the estrogen will be increased. Or rather, no, that's not what I wanted to say, basically. Okay, so yeah, it means that if it's reduced, it means that estrogen, sorry. Here, what it means is that the FSH is reduced and thus estrogen will be reduced. So this patient will have what we call hypogonadotropic hypogonadism. Hypogonadism. So if the FSH is reduced, estrogen is reduced, this patient will have hypogonadotropic hypogonadism. This is in contrast to what we have on the other side here, right? This is in contrast to what we have on the other side, where when you check the FSH level is increased, right? But the estrogen level is reduced. And so this patient will have what we call hypergonadotropic hypogonadism. So let me summarize everything I've said here, basically. So when you have a sex disorder, a question on sex disorder, there are certain things you have to look for in the question. It's very tricky, and the examiners kind of know how to, twist this question to make it a bit difficult for students to kind of like get it, basically. And so, so basically what you have here is that the patient, you look at the uterus. If the patient has a uterus or does not have a uterus, right? If the patient has a uterus, you'll be thinking more of a female. If the patient does not have a uterus, you can be thinking whether the patient is a male or a female. Let me use that. I think that's better. So if the patient, then what you now do is that you now look at whether the patient has breasts. If the patient has breasts, you're thinking of the next thing you want to think about is the pubic hair. Is it well developed? Is it underdeveloped? Is it even present at all or not present? Now, if it is present and genetically the patient is a male, you'll be thinking of androgen insensitivity syndrome. If it's not present and the patient has a breast but not uterus, and the patient is a genetical female, you're thinking of Mullerian agenesis, right? And then when you go to the other side of the table, the patient has a uterus, definitely confirmed. You do a karyotype study, the patient is genetically female. You check for the breast. If the patient has a breast, you're considering the patient is genetically and anatomically a female. If the patient does not have a breast, the next thing you want to check is the FSH level. Why is this patient not having a breast? Because I told you that breast indicates that there's hormonal production or not. And if this patient does not have a breast, the next thing you want to check is the FSH level. What is the FSH level? Check the FSH level, you check the estrogen level, you notice that both of them are down. You're thinking of hypogonadotropic hypogonadism. You check the FSH level, the FSH is high, but estrogen is low. You're thinking of hypergonadotropic hypogonadism. I don't know if that is pretty much straightforward.
Doc, could you repeat the last part when the FSH is low and then the estrogen is high?
Okay, so if the FSH is low and the estrogen is low, you are thinking of hypogonadotropic hypogonadism. But if the estrogen is low and the FSH is high, you are thinking of hypergonadotropic hypogonadism. Okay, let me go over. Okay, Dr. Nafia, you said I should go over it again. And so let me just try and explain this, right? I said that when you're faced with a question that has to do with sex disorder, you're going to look at two things in the question. You shouldn't look at the age and the sex of the patient. Sometimes it should be the last thing you should think of. It should be the last thing you address in the question. That's what I'm trying to say. I'm trying to say that it should be the last thing because there are other things, cues in the question that can kind of like give it out, right? And the things you're going to look at is you're going to look at the uterus. If you look at the uterus and in the question they tell you, oh, the uterus ended in a, or they tell you that the patient does not have a fallopian tube, does not have ovaries, does not have a uterus, or the vagina ends in a blind-ended pouch, it means that, oh, The uterus is not there basically, and so the patient does not have a uterus. That's the first thing you need to know. So if the patient does not have a uterus, you now look at the question. This is when you now go back to the question and look whether it's a male or a female. Then you now come down and ask, does this patient have a breast? If the patient has a breast, then you're not trying to look at other things apart from the sex and the age of the patient. If the patient does not have a breast, then the patient genetically is a male, especially if they tell you in the question that the patient is a male. If they tell you in the question that the patient is a male and he does not have a uterus, then he has breast, you're not trying to find out why does this patient have a breast? Because I told you that the breast signifies that there's overproduction, or the receptors are not kind of like receptive to the androgens basically. And so you have to check the pubic hair. Sometimes they put it in the question, they might say the Turner stage. They might tell you that the patient's Turner stage is stage 1. So it tells you that the patient's pubic hair development is reduced. And so if that is the case, I want you to think of androgen insensitivity syndrome, especially if the questioner tells you that he's a 16-year-old male, possibly he has not been menstruating, or is a female, something like that. They try and confuse the question in a way for you not to kind of like get the answer. But what I want you to do is to look at the fact whether the patient has a breast and if the patient has a uterus, basically. Those are the two things I want you guys to do. If the patient does not have a breast, if the patient does not have a uterus, meanwhile has a breast, I want you to look at the pubic hair. If you look at the pubic hair and it is present, I want you to think of androgen insensitivity syndrome. Now, I want you to look at the other side. The patient does not have a uterus, but the patient has a breast. So it could mean that, oh, the patient actually is producing estrogen, but the Mullerian duct is not formed. And if the Mullerian duct is not formed, it means that the patient will have Mullerian agenesis, and the patient genetically is a female, not a male, not a male. I just put this here for like, it's a kind of way for me to remember this stuff. It can be confusing, but it's a way for me to kind of remember it. So Mullerian agenesis will occur more in females. That's what I'm trying to say. It will occur more in females. It will occur more in females. That's what I'm trying to say. The patient will not have pubic hair. So I summarize it here. I said that in Mullerian agenesis, the patient is genetically a female, but there's no uterus, but looks like a male. Looks like a male because the patient will having clitoromegaly and all those things, but have virilization, but the patient has a breast, right? And genetically is a female. So outwardly, the patient has features of a male, but inwardly, the patient doesn't have a uterus, but can have ovary. Sometimes in the question, they might tell you that the patient has a uterus, an ovary. Sometimes they might not tell you. They might not put it in the question, right? I now say that when you go to the other side of this table, of this graph, you see that I wrote here that the patient is a female. Like it's a female because the patient has a uterus already. It is confirmed that the patient is a female. And then when you see that, when you check the patient, you ask whether the patient has a breast. The patient has a breast. The patient anatomically and genetically is a female. That's why you say I wrote F here. But if the patient doesn't have a breast and has a uterus, the next thing you want to ask yourself is that this patient, what is the hormonal level? Is this patient producing high hormones of estrogen and FSH, or this patient is not even producing FSH at all? And so you want to think of two things. If the patient has a very low level of TSH and a very low level of estrogen, this patient has hypogonadotrophic hypogonadism. If the patient has a increased level of FSH but a low level of estrogen, this patient has hypergonadotrophic hypogonadism. That's what I'm just trying to illustrate in that diagram there. Does it make sense, Dr. Nafia? Right. So what I want you guys to remember for the both of them, basically, this table is how I kind of like answer questions for sex disorders. It makes it a lot easier for me to compartmentalize the question, and most often than not, I'm able to kind of like figure out what is correct and what's not correct when I'm able to like draw this table, right? So that's basically what you just have, basically, right? That's basically what you just have. I don't know. Do we have any other questions here? So the part I'm going to talk about is the 5-alpha reductase. I just want to talk about that quickly. So for the 5-alpha reductase,
Okay, doctor.
yeah,
Can I reiterate that if there is initially no uterus, but initially there is no uterus, but there is breast, then I'll
yeah,
check for pubic hair.
yeah,
If the pubic hair is present, then it will be androgen insensitivity syndrome.
yes,
Yeah,
yes,
that's right. Okay.
yeah,
But if there is no pubic hair, then there will be Mullerian agenesis.
yes. And then in
Okay, I'll
malaria
refer
genes, yes,
agencies, but there will be breast tissue and the ovaries will be present,
yes,
but there is not initially no uterus. But if
yes,
initially uterus but no breast, then I'll go for, if there is FSH level, I'll check for FSH levels increased or decreased, right? Yeah,
yes,
if FSH levels are increased, so there it will refer to hypergonadotropic hypogonadism.
yes, that's correct.
Okay. Thank you.
Okay. Yeah, so I want to talk about 5-alpha reductase, and basically what happens in 5-alpha reductase is that this patient, so basically this patient has, so basically this patient, what this patient has basically is that 5-alpha reductase is that this patient is able to produce, now testosterone is converted to its active form. Its active form is DHT, dry hydrotestosterone. Right? And then DHT is responsible for the internal genitalia of a patient. Internal genitalia.
It's for external genitalia.
Yes, for external genitalia.
DHT is for external genitalia.
Or external?
External.
External.
Yeah. DHT.
Okay. Sorry. Kind of mumbling it up. Okay, so let me correct myself. Sorry. Kind of like fatigued today. I don't know why I'm just making a lot of errors.
No problem. No.
So this is like the external genitalia, right? External genitalia. So what basically happens here is that for the external genitalia, we're talking about organs such as the penis, right? The scrotum. And so testosterone needs to be converted to this by this enzyme 5-alpha reductase. And so if this enzyme is kind of like missing, that won't happen. And so this patient you're seeing right here, we have no external genitalia, but the internal genitalia is present. Thank you, doctor, for correcting me. I don't know, I'm a bit fatigued today.
Welcome, sir. Welcome.
Yeah, so basically this guy is a genetic male, right? Well, here's what happens. This is what happens basically. Before this patient attains puberty, this patient will be looking like a female. So one thing that gives the question away is that they will tell you about a female looking like a patient that has not seen a period for over a while. And then when she got to puberty, they started noticing that this patient started having sexual secondary characteristics. There's pubic hair and all of that basically. But initially, this patient will appear like a female, right? So in 5-alpha reductase, how the question usually comes is that the patient will look like a female prior to puberty. And then in puberty, you start noticing male-like changes, right? Male-like changes, there's pubic hair and all that. You know, that's typically how the question goes. And then the patient's external genitalia is not present, right? The patient looks like a female, but when the patient gets to puberty, starts having these rapid male-like changes, the voice becomes thickening, you know, the voice becomes thickened, the pubic hair starts developing and all of that, because there's a rapid increase in testosterone as the patient achieves puberty. So that girl-like child that they told you in the question, that's why I told you that when you look at the question, do not look at that first sentence where they tell you, oh, a 16-year-old girl or a 16-year-old male. Don't look at it. Look at the other parts of the questions. That is where the answer is. That is what gives the answers away. You should look at the age and the sex after you have analyzed the symptoms. That is when you can now go back to that first sentence where they tell you a 16-year-old male or female. But when they give you the question, I want you to take that first sentence, a 16-year-old male or 17-year-old female, with a pinch of salt. Look at the symptoms that follow that sentence. When you have analyzed it using these charts that I told you, then you can now go back to that first sentence to be able to piece it all together to make a diagnosis. Because 5-alpha reductase, the patient has a normal external genitalia, has the testes, has all those things, the seed symptoms, the seed organs, but however, does not have an external genitalia. So the patient will be looking like a female. So this is very important for you guys to know for the exam, especially for the steps. So you just need to go over it, go over this table, be able to go over the table, understand this algorithm I gave you, and it will become a lot more easier by the time you attempt questions, right? Another very common syndrome that I want you guys to know that's very high yield is the Kalman syndrome. Kalman, K-A-L-L-M-A-N. And so what happens in Kalman syndrome is that there's failure of neuronal migration to the hypothalamus. And so the gonadotropins are not kind of like secreted. And so this patient, usually a male patient, presents with loss of smell. I think there's an MBME question where I saw loss of taste. I don't know that MBME question. I saw an MBME question that talked about it, but they didn't talk about the loss of smell. In the question, they put loss of taste. And in the options, they chose Kalman syndrome. So I just want you to know, in addition, that you can have something like that in the MBME so that you're not shocked when you're answering the question. I don't know if that is clear. Do you have any question about this aspect? The next thing we want to talk about is painful vaginal bleeding in pregnancies. Painful vaginal bleeding in pregnancies. And so when you see a question about painful vaginal bleeding in pregnancies, I want you guys to think of two things, right? Bleeding in pregnancy. So bleeding per vaginum. A woman is pregnant, she's bleeding per vaginum. I want you to think of two things, two questions. Is it painful? Is it painless? Painful, painless. If it is painful, I want you to think of two things, either uterine rupture or abruptio placentae. Let me put AP. Abruptio placentae. If it's painless, I want you to think of placenta previa, and vasa previa. Anytime you see the word previa, I think it's a Greek word for before. So placenta previa, before the placenta. Vasa previa, before the blood vessels. So now placenta previa is a situation where the placenta kind of like is located just above the cervical os. And so when a woman is pregnant, within the first to second trimester, there's a rapid growth of the placenta. And if this placenta is here, which we call a low-lying placenta, a low-lying placenta is a placenta that's less than 2 centimeters from the cervical os. Ideally, as this womb is growing, this placenta is supposed to go up with it as well. That is what's supposed to happen. But there are situations that will prevent the migration of this placenta upward. And we call these situations risk factors for placenta previa. The first one is that the placenta itself is scared of implanting in a place that has a scar tissue. So anywhere that you have a scar tissue, the placenta doesn't like going to that region. And so if a patient, for example, has an infection in the uterus, endometritis or surgery or anything, and there's a scar tissue in the upper segment of the uterus, the placenta would not want to migrate upward or implant upward. It will prefer to come downward. That is one reason. The second reason is that if you had a previous history of placenta previa, the second placenta might want to implant in that same position. And so a previous history of placenta previa is a strong risk factor for having a subsequent placenta previa in the next pregnancy. Now, you can have a situation where you have multiple pregnancies. And so the placenta can implant in several positions. If you have, so the more pregnancies you have, so the patient's parity also increases the risk. Because once a placenta implants in this upper segment, it has no choice but to come downward. So if the first baby implants here, the second baby wants to implant here, the third baby wants to implant here, and maybe the fourth baby might implant on the os of the cervix. So gram multiparity or increased parity is a risk factor for placenta previa. Also, multiple gestation, you have multiple twins in here. The next pregnancy, the placenta will not want to implant in where the previous placenta implanted in the previous pregnancy. It will want to come downward. And these things can increase the risk of having placenta previa. Now, in the second trimester, the patient might have what we call a warning bleed in placenta previa. And this is very high yield for you guys to know. Patient usually has a warning bleed in pregnancy. And the bleeding in placenta previa is usually kind of like bright red. And usually the mother is more affected in placenta previa than the child. And so for patient to placenta previa, you do an ultrasound scan before you do a VE, a vaginal examination. If not, you would traumatize the placenta and the woman will bleed. The bleeding in placenta previa is usually very painless. Right? And so when a patient, there are different grades, you don't need to know that for the exam. The treatment of choice for a patient with placenta previa is cesarean section. So you do a CS, then you save the baby. For a patient with vasa previa, what we basically have here, and the most common abnormality that you can find here is what we call a velamentous insertion of the umbilical cord. So let me explain what that means basically. A velamentous insertion, so let me write AP, is a situation where the placenta blood vessels, right? The placenta blood vessels are supposed to be covered by something called a Wharton's jelly, and they are supposed to be inserted into the central part of the placenta. So this is the placenta. The blood vessel is supposed to be inserted into the central part here. And this part here is usually covered by Wharton's jelly. So the blood vessels is inside here and is surrounded by Wharton's jelly. So let me just draw this for you guys. So this is how the umbilical cord looks like. So this is the umbilical cord. So you have the eyes that represents the arteries, and then you have this long vein that represents the mouth. And so these surrounding structures here that you're seeing, these surrounding structures you're seeing here, is covered by a jelly known as Wharton's jelly. So it's covered by Wharton's jelly. Wharton's jelly. And so what happens in this velamentous insertion is that instead of the umbilicals attaching to the placenta, something like this happens. So let me draw the womb. This is the baby. The placenta comes here and attaches to the chorion. So it attaches to the chorion. And then the naked vessels of the placenta, the naked vessel, let me signify this with red. The naked vessels crosses the cervical os and, you know, inserts here. But this vessel has already inserted, is already attached to the chorion. And so this vessel that leaves this attachment point is now naked. It does not have any covering. Or here has a covering. The attachment of the umbilical vessels to the chorion is known as the velamentous insertion of the blood vessels. And then the blood vessels that leave this attachment of the umbilical cord to the chorion are now naked without the Wharton's jelly. And these vessels here are very delicate and friable. And so when the fetus grows and attains a larger size in the womb, so when the fetus attains a larger size and the head is here, it can just clamp on these blood vessels, clamp on this blood vessel, and the woman just starts bleeding profusely. When that happens, we call it vasa previa. That bleeding is called vasa previa. Vasa previa is usually associated with certain disease conditions. And one of those disease conditions is known as a single umbilical artery, which I told you guys in the last class, usually associated with chromosomal abnormalities. Now, the next thing we want to talk about is on this side, painful bleeding. Patient presents with painful bleeding, and this patient becomes very hypovolumic. You're thinking of two conditions, abruptio placentae, or you're thinking of uterine rupture. In uterine rupture, they would usually tell you that this patient had a previous surgery, maybe a myomectomy or maybe a previous serious, something like that. And then the patient is having painful pain as well as vaginal bleeding, and this patient is going into shock, you know, that kind of situation. And of course, you want to take this patient into the OR to try and, like, you know, close up and ligate the blood vessels, the bleeders. The artery you want to ligate, or the artery that you want to ligate in this patient is usually the uterine artery, because it kind of like runs through the cardinal ligaments by the side. And so when you go into the patient, you want to clamp that, or you want to do an internal artery embolization so that the patient doesn't bleed, because this is one of the commonest causes of postpartum hemorrhage. And so you want to kind of stop that by clamping, taking the patient to the OR and trying to do the needful. For abruptio placentae, basically, this patient is having a situation where the shearing of the placenta from the uterine wall. And so this bleeding is usually painful and affects the fetus more. All right. The risk factor for this is smoking in pregnancy or cocaine use. Cocaine use, hard drug, common use, common risk factors, smoking, cocaine. These are common risk factors. And then hypertension is also another thing that is very common cause of it. DM, chronic medical conditions can increase the patient's risk of having abruption placentae. Also, primary gravity is also another risk factor for it. So these are all risk factors that you must know for the exam and are commonly tested. So how do you manage a patient with abruption placentae? The most important thing is to deliver the fetus as soon as possible, because if you leave the fetus in the woman's womb, the fetus will exsanguinate, and then you have a IUFD, right? Do we have any questions at this point?
I do have a question.
Yeah.
So my question is not in regards or to what you just said. It's the previous one when you talked about the syndrome. So my question is this common syndrome related to telesencephalon? Because you said it's failure of neuronal migration. Is it related with
Yes.
yeah.
Yeah, so it's different because in Kalman syndrome, the neurons that are affected are neurons that have to do with the neurons that are responsible for producing the gonadotropin releasing hormones,
Okay.
basically.
Okay.
Yeah, so they're different from that. So Dr. Nafia, talking about the Watson's jelly one more time. Okay, so let me talk about that. So I said that the Watson's jelly, basically, when I drew the umbilicus, I drew the two arteries, which are the eyes, and then I drew this large big vein here. And I said that in between this artery and the veins, they are like connective tissues that kind of like cushion the blood vessels inside the umbilical artery. Those connective tissue are jelly-like in nature, and then we call them Watson's jelly. So what basically happens is that when the umbilical vessels coming from the fetus is trying to go across to this part of the placenta, they kind of like attach or insert into the chorion. The chorion is one of the membranes that surround the fetus. And so when these blood vessels attach to the chorion strips the umbilical vessels of this Wharton jelly. And so the remaining vessel that crosses and goes over to the placenta lacks this protective jelly around this place. And so this protective jelly that is not on these vessels as they go up here, it causes these vessels to be at risk of rupture. Hence, for patients with vasa previa, you do not want them to deliver vaginally, because once the head of the fetus just touches those vessels, it ruptures and the patient bleeds. So the Wharton jelly is just like a connective tissue that kind of like cushions the umbilical artery and the veins in the umbilical cord. Kind of like give it kind of like supporting in nature. Yeah. And so if it's absent, those vessels are friable, they are very prone to rupture, very prone to bleeding, and then the patient can come down with vasa previa if he bleeds or if the patient head just clamps on it. I don't know if that's clear. Okay. Ectopic pregnancy basically is the next thing we're going to talk about. This is very easy. I don't need to spend so much time here. But for you guys to know, we have two types of pregnancies basically. We have the intrauterine pregnancy, and then we have the extrauterine pregnancy, right? And ectopic pregnancy is one of the types of extrauterine pregnancy, or it's the commonest type of extrauterine pregnancy. So what basically happens here, not extrauterine, okay, let's say, yeah, extrauterine, because it's not within the uterus. So let me use that word. So what basically happens here is that, of course, you have the ovum, this is the fallopian tube, right? This is the uterus, fallopian tube, right? The egg. So what you have here basically is the egg is being released here and it's coming down here, right? This is the fimbrate, this is the like the fallopian tube. And so what happens here is that the sperm comes in and meets this guy over here, and then they meet and then fertilization occurs. Now, when fertilization occurs, the next thing the zygote wants to do is to find a place that will help it to support its growth and nourishment. And so anything that looks like a muscle or an epithelium, it will just go there and implant. When this happens, this is the pathophysiology of ectopic pregnancy. So implantation of the ovum or the fertilized egg outside the uterus, outside this place here. So when there's fertilization and implantation of this egg outside the uterus leads to ectopic pregnancy. And so how does the body sort this out, right? The commonest region is the ampulla. And then the one place you would not want this egg to implant is here, which is more like the isthmus. Around this region here is the isthmus. The isthmus is the narrowest part of the fallopian tube, and so you don't want this egg to implant in this region here, right? But here's a problem. There's something that is causing the delay, because ideally it's supposed to take about 1 day, 1 to 2 days for this egg to get to this point here where it will be fertilized and then it will implant. That means for this process to occur, something is delaying the egg from reaching this region at the right time. And there are several things that can cause it. Now, something helps with the transportation. The last time I talked about the epithelium of the fallopian tube, I told you that the epithelium of the fallopian tube is simple columnar ciliated, meaning it has finger-like projections that kind of like beats in a particular direction. So they beat in this direction. And the essence of beating in this direction is to try and push the egg to enter into the uterus as soon as possible. So anything that would affect the beating of the cilia or cause a delay in this region here, the transport, or block the transportation, will cause ectopic pregnancy. So PID, which is the commonest cause, you can have a patient who has PID, scarring of this tube. Patient can't have the eggs can't move as they're supposed to move. The patient can come down with PID. Previous surgeries, and touching of the fallopian tube, adhesions can also prevent it from going in. And these are just some of the things that you need to know about these conditions, right? So that's what I want to just tell you guys, right? So let's just get that. So how do you manage this situation? How do you manage this condition, basically? How do you manage this condition? It's kind of simple. What you want to do basically is that you want to go in and try to either remove the ovum from when it's implanted so that everything kind of goes back to normal, basically. That is the one that is causing significant hemodynamic instability. But if it's one that the patient is asymptomatic and is not in a place that can cause rupture easily, you just want to do a medical treatment, and the drug of choice that is used is methotrexate, right? And this drug is given according to so the dose that I know is 50 milligrams per meter square. This is the dose of it. So you're giving it at this dose basically. To kind of this is the dose you give. Use the surface area. Use the surface area to kind of help with the administration of the drug. Another thing I failed to mention when I was talking about the placenta disorders, and let me just quickly talk about that. I'm sorry that I'm going back and forth basically, is that sometimes you can have a situation where the placenta inserts adherently to the myometrium. And so we have 3 conditions. I call them the AIP. The AIP condition. So we have accreta, increta, and precreta. So for the accreta, the placenta is strongly adherent to the decidual bacillus. So what happens here is that the placenta is strongly adherent to the decidual bacillus, right? It gets to the myometrium, but does not perforate it. So it goes more. So let me just show you guys what I'm trying to say here. Let me draw you a diagram here. Right? So this is the decidual bacillus. So it attaches to it, perforates it. It gets to this guy here. It attaches to it. So this is the villus, the trophoblast. The villus gets here, attaches to the myoblast, to the myocytes. but does not perforate it. The increter comes, perforates this guy, attaches itself here. So this is the myometrium. So the increter, this is the increter. This is the accretor. So the percretor comes this way, perforates the myometrium, perforates the serosa and all other parts, and attaches to an end organ, basically. And this is the percretor. This accretor is the most commonest. And one of the risk factors to this condition is previous surgeries. Like I told you, the placenta doesn't like scar tissues. However, if it implants in a scar tissue, it hardly removes itself from that scar tissue. And so one of the risk factors for this condition is usually previous surgeries. Right? Previous surgery is one of the commonest causes of this condition, right? Okay, so but for ectopic pregnancy, there are various sites. It can implant extrauterine, it can even implant in the peritoneum, it can implant in the isthmus, it can implant in the ampulla, it can implant in the isthmus, and it can also implant in the greater horn of the uterus. So these are all sites. The treatment of choice, the patient will present with a triad of amenorrhea, vaginal bleeding, and pain. So I usually call it BAP. And usually what you have in this patient is that the beta HCG rises, but it doesn't rise as it's supposed to rise. So beta HCG will be increased. So what happens is that beta HCG is supposed to double every 2 days, right? It's supposed to double every 2 days. And that is the sign of the fact that the embryo is inserted into the myometrium. When you see that there's a slow rise in beta HCG, a very slow rise in beta HCG, the patient is amenorrheic, is having abdominal pain, and then the patient is having vaginal bleeding. I want you to think of ectopic pregnancy until proven otherwise. Does that make sense, guys? Okay.
So sorry, could you repeat that sentence again?
Okay, so I said that ideally the beta HCG is supposed to double every 48 hours. And this is an indication that the embryo, the fertilized embryo, is inside the womb. It's inside here. It's a testament to the fact that the embryo is implanted in the endometrium. However, for patients with ectopic pregnancy, the beta HCG rises, but it rises very slowly, right? When you see that in an exam question, they tell you that the beta HCG is not rising as it's supposed to rise. The patient is having bleeding per vaginum, having amenorrhea. I might tell you that the patient didn't see his period for the past 7 weeks, 7 weeks gone, and then the patient is having abdominal pain. I want you to think of ectopic pregnancy until proven otherwise. So the BAP symptoms plus a slow increase in beta HCG, and when you do an ultrasound scan, you discover that there is no implanted ovum in the uterus. It is ectopic pregnancy until proven otherwise. Does that make sense, guys? And so the next thing we're going to talk about, basically, I'm just going to rush over this quickly so that we can try and finish up, because the last thing I'll talk about is what we call molar pregnancies, right? So molar pregnancies, I'm just going to explain what basically happens here. Molar pregnancies is a situation, we have a situation where we have the patient doesn't have an embryonic egg is fertilized by a sperm cell. So basically, you have an egg here. It's supposed to have an ovum here. And then this guy meets with a sperm cell. And then this egg what you have here in this egg is that, yes, this egg does not, this follicle or ovum, whatever, or a follicle, this follicle does not have any egg. So it's an anucleated. Anucleated egg. So these two fertilize each other, and when they fertilize each other, they don't form a zygote. They form what do you call it now? They form a tissue that does not have fetal components, basically. So the only thing that this thing we have basically is just placenta tissue. What you need to know basically is that the other part of the egg is capable of fertilizing, is capable of coming together with a sperm cell to form a structure. But because there is no egg in this thing, there's no egg here, what you only get is a placenta tissue, right? Now, because the placenta tissue is what produces beta HCG, this patient will, you see this patient, when he does a urine test, will have a high beta HCG level. And the patient will assume that he's pregnant. And of course, the tummy will be growing, will be becoming bigger and bigger, but there's no fetus inside the tummy. So what you just have is just placenta tissues, right? And another thing I want you guys to know here is that beta HCG itself has two parts, two subunits. It has a beta subunit and it has an alpha subunit. The alpha subunit shares the same unit with LH, FSH, and TSH. So in some scenarios, the TSH receptors can be activated by beta HCG because they share the same alpha subunit. And so a patient that has a molar pregnancy, what you do for the patient is called a dilatation and curettage. That's how you treat it. Now, there are two types of molar pregnancies, and I have to emphasize on this. There are two types. We have the complete and the partial. Now, the complete basically is that, what happens in the complete basically is that, so let me write a table here, complete and partial. In the complete, you have just one ovum, right? That does not have an egg coming to meet a sperm, right? And so this nucleus, all you will have here is just placenta tissue. There will be no fetal parts. No maternal contribution. So there's no maternal contribution to the formation of this structure. Only fetus, only placenta tissues rather. The maternal contribution meaning that there's no nucleus, there's no egg inside, basically. Now, this is against the partial where you have, so basically what you have here, this guy is only bringing his own chromosomes. So basically you have a 46XX. So these X, the two X are coming from the male. There is no one coming from the female. And usually, it's usually supposed to be one X from the female and maybe an X or Y from the male. So basically, the male will either give an X to this and a Y to this, but there's no nucleus here. So fetal cells will not be produced. So this patient either has an 45XX or a 45XY. The partial, on the other hand, you are having two sperms that are coming to fertilize one egg. And this egg may or may not have a nucleus. So two sperms, one is coming here. So this egg may or may not have a nucleus inside. And so this patient, what you have when you have two sperms, so it means that the chromosome will be more. And so you have something that looks like this. 69 because it's two chromosomes. So instead of having two pairs of chromosomes, this patient will be having three pairs of chromosomes. That's why it's 69 because 23 23 times 3, because it's, of course, you know what I mean. 23 times 3 is 69. So 2 sperms are coming, which is 46 already, to meet an egg that's already 23. And when you sum this together, you have 69 basically. So this patient will have 69, either X, 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 or X, X, Y. Yeah, Dr. Adi. Your question.
Excuse me. Yeah. In complete mole, we have just one sperm, so one single, 23 set of chromosomes. So why we have X, Y, or XX? There's just one, so it would be X or it would be Y.
Okay, so basically, what is happening here in the complete mole basically is that it's the sex chromosome that is mixing, right? In this patient, in this particular scenario, but the patient can, in some rare scenarios, can have other chromosomal contributions. So the sperm cells is coming to meet a somatic cell. It's not coming to meet a how will I explain now? It's not coming to meet a sex chromosome. It's coming to fertilize an autosome. It's coming to fertilize another tissue. It's not coming to fertilize. How will I put it now? How do I explain this that it makes sense to you? So it's coming to fertilize a cell that has all other pairs of chromosomes, but it doesn't have a sex. It doesn't have a sex chromosome. Let me use that word. So the sperm cell is bringing its 23, right? It's 23 chromosomes. The other cell is bringing like the cell without the nucleus. The nucleus is where the sex chromosomes are basically. So it's coming to fertilize a part of the cell that is not the sex chromosome. I don't know if it makes sense. That's like the simplest way I can kind of like put it for you. So it's coming to fertilize a cell that does not have a sex chromosome. So it's depositing its 23X or 23Y to a somatic cell, to one of those pairs of chromosomes. That's one of those 22 pairs of chromosomes. It's not coming to deposit its egg to the sex chromosome, one sex chromosome, because the sex chromosome is located in the nucleus. It's located in the egg itself. Do you understand what I'm trying to say? So it's like the sperm coming to fertilize a cell that is not the ovum. Let me just use that word. I think that's the best way I can put it, or like the simplest way I can put it. I don't know if that makes sense. That's how I like picture it. That ideally you're supposed to have a sperm that comes and fertilizes an egg. But instead of coming to do that, it comes to look for another cell in the egg and fertilizes it. Deposits its XY to one of those cells and replication occurs. Right? I'm not really a strong molecular scientist. I might not really have the best answer, but to me, that's how I like kind of put it in my mind. Yeah, it could be. It could be. But what I'm trying to say here is that you said, can it be after fertilizing that there will be duplication of chromosome? Yes, it could be. It could be. Maybe that's why. So it could be that it fertilizes it, there's no egg, and then it duplicates it. Of course, that's what happens for all cells. All cells have to undergo that synthesis phase before the division phase. So yes, it could be. It could be basically. So I agree with you. It could be that there's the duplication. Maybe that's why. So you're saying, where does the 2x come from if the father only has one egg? So if the father only has, no, it's one sperm that is coming. What I'm trying to say here basically is, and I think this guy just helped me with the answer, a very logical answer to it, right? So basically what happens here, what I think is the most reasonable explanation for this, sorry, I'm not a molecular scientist. I might not give you the best answer, and I might also research on this myself. Basically, what happens is that the father is coming with 22 pair of chromosomes. So, and then one pair of either X, Y, one pair of XY or one pair of XX. And so the father comes in, fertilizes an empty egg, attaches to a cell, and then the patient will now have the embryo will just have a 23, maybe XX or XY. I'm just trying to guess what happens. I'm not saying this is what happens basically. I'm just trying to guess what happens here. And so these cells might undergo duplication before mitosis. So this cell might duplicate, and then you might have a 46XY, or you might have a 46XX. So duplication or synthesis might occur. So I think Dr. BN gave a very more reasonable explanation. That it can be maybe there's a duplication of chromosomes or something. Maybe that's why. I don't know. I'm just postulating basically. I'm just postulating. I'm just saying I'm a molecular scientist. I might not have the best answers to this. Yeah. So maybe you guys can read on it. I'm not a political scientist. I've just known it to be like this. Yeah, so duplication might be the reason. Yeah, duplication might be the reason. Thank you, Dr. Sharon. That could be a very reasonable explanation to it, right? And the same thing happens with, 2x coming, duplicating, forming 69XX or 69XY. So maybe that's why, right? So that could be the reason why we're having this. I don't know. I feel, but what you need to know for the steps is that among these two, this is the most common one. This is the most common for the complete mode. This is the most common one you have, right? And for the complete, there are no fetal tissues. All you would see in the complete is that you would see just hydrophylies, diffuse hydropic villi rather. So you see hydropic villi, and these hydropic villi are diffuse and hyperplastic. So everywhere of the uterus, you would see placenta tissues everywhere. And if these things organize themselves, if the villi organize themselves in a rosette manner, they will form what we call, there's a word they call this thing. Is it strings of pearl appearance? String of pearl appearance. So that's what you see in the complete. And another thing you need to know about the complete is that the complete increases the risk of choriocarcinoma. So among both of them, the chances that the choriocarcinoma, which is a tumor of the gestation, what do I call it now? The trophoblast, basically. There's a more increased risk of developing choriocarcinoma from the complete as against the partial. And another thing you need to know about the complete is that the beta ECG is very high. You can see the rate of 500, 1,000, 1 million. The level is usually very high. And the most striking thing I want you guys to take for the exam to know is that this string of pearl appearance you see on ultrasound scan, and then the eye drops usually diffused and there's rapid enlargement, right? And then the beta ECG is usually normal. For the partial, there's a presence of fetal tissue, and then the hydropic villi are not as much as what you see in the complete. It's usually very minimal. Usually very, very much minimal. The treatment for this basically, in most cases, is to use methotrexate. That's the treatment of this, or do a D&C. D&C is also very effective. A dilatation and curettage. But most times methotrexate is very good. The reason why methotrexate is very effective is that these tissues are rapidly dividing tissues, and they need a lot of folate to do that. Hence, if you can block off the supply of folates to these cells, you would stop the growth of those tissues. The last thing we're going to talk about is the choriocarcinoma. And the choriocarcinoma is usually a tumor of trophoblastic cells. What I want you guys to know is that what is very much important for the exam is that it's a tumor of trophoblast cells, 15% of the cases arise from a complete mole. And these patients usually present with vaginal bleeding. Vaginal bleeding. They also present with gestational hypertension. Now, the reason why they present with gestational hypertension is not clearly understood. But this is one of the causes of gestational hypertension below 20 weeks. Molar pregnancies, gestational choriocarcinoma, and all these gestational trophoblastic disease are one of the causes of gestational hypertension below 20 weeks. Ideally, gestational hypertension is supposed to happen after 20 weeks. But it's only in molar pregnancy that you can have a patient having gestational hypertension and the patient is not even up to 20 weeks. Another thing that's very common about choriocarcinoma is that it loves metastasis to the lungs. I don't know why it loves that, though. I don't know why it loves metastasis to the lungs. So the patient presents with dyspnea and hemoptysis. So in a question where they tell you a woman is pregnant, she's having vaginal bleeding, presents with dyspnea and hemoptysis, you do a pregnancy test, it's positive, beta ECG is very high, you can just ask you what's the diagnosis. And so choriocarcinoma is the diagnosis. It's a tumor that affects trophoblastic tissue. 15% of it arises from the vagina, from the complete mole. And then the treatment of choice for choriocarcinoma is methotrexate, like I said. These cells are rapidly dividing, and you want to give these cells, you want to kind of cut off the source of the substrates that these cells use for division. Hence, you give that medication. So I think we're going to stop here today so that you guys can have your UWorld session. You have any questions? Cannon-borne metastasis, yes. Yeah, this can be correct too. Who put this up? Let me see who put this up. Yeah. So yeah, Dr. Asi, that is correct. Yes, you can have a scenario like this too. Yeah, I agree with you. So guys, we'll see in the next class. We'll start vulvar pathology, and then we'll see how far we can go and try and finish it up. We still have a lot of pathology.
Can you please make sure that this recording is uploaded to the Dr. Ahmed, because some of us miss beginning of the class or last phase of the class. Let's say please make sure the recording is uploaded to Dr. Ahmed.
Yeah, I'm going to tell him to do that right now. Immediately I just end this class.
Yes.
Yeah.
It's a long class. Yes, long class. That's it. Thank you.
Okay. So no problem, guys. Thank you for the session. Thank you, Dr. Agzi. Thank you, Dr. Miriam, for correcting me. I'm a bit fatigued.
Thank you so much. Thank you so much.
Thank you, doctor.
Yeah.
Thank you.
Yeah.
Thank you.